Welcome to Nexus Clinical. Before diving into this lecture, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures. The rapid development of cellular and genetic medicine has introduced a transformative class of therapeutics, poised to change how many diseases are treated, from rare monogenic disorders to complex cancers. For healthcare professionals navigating this complex field, a clear understanding of the core principles, terms, and strategic differences that define these advanced therapies is crucial. This material provides the essential framework to distinguish between cell therapy, the use of living cells, and gene therapy, a molecular approach to alter gene expression, while also explaining their important overlap in gene-modified cell therapy. Additionally, it outlines the two main strategic methods used in clinical practice: in vivo delivery, where genetic modification takes place inside the patient, and ex vivo modification, in which cells are engineered outside the body before being reintroduced. Understanding these key concepts is vital for appreciating how the cellular vehicle and its genetic payload work together, shaping the complexity and potential of modern genetic medicine. Upon completing this content, healthcare professionals should be able to clearly differentiate between various modalities of gene therapy. They should be able to distinguish the core concepts of cell therapy, gene therapy, and the hybrid approach of gene-modified cell therapy, recognizing the active therapeutic agent in each. Additionally, they should be equipped to explain the fundamental biological and logistical differences between in vivo strategies, which involve direct delivery, and ex vivo strategies, which include laboratory modification, and identify which disease types are most suitable for each approach. Professionals should also analyze the primary characteristics of viral vectors, such as adeno-associated virus and lentiviral vectors, specifically contrasting the episomal nature of adeno-associated virus with the permanent genomic integration of lentiviral vectors. They need to evaluate the safety risks associated with gene therapies, including major genotoxic and immunological concerns such as insertional mutagenesis for vectors that integrate into the genome, off-target effects from gene editing, and the presence of pre-existing neutralizing antibodies against adeno-associated virus. Understanding RNA therapeutics involves describing their mechanisms of action, including their transient effects and safety advantages. This encompasses non-integrating therapeutics like messenger RNA encapsulated in lipid nanoparticles and antisense oligonucleotides. Healthcare professionals should also be able to distinguish the goals of different genetic manipulation techniques, contrasting gene replacement strategies used for loss-of-function conditions with gene silencing or gene deletion methods utilized to address toxic gain-of-function scenarios. Furthermore, they should be able to relate specific therapies approved by the Food and Drug Administration. Examples include Zolgensma, Kymriah, and Cabometyx, with an understanding of their vector types, mechanisms, whether they involve gene addition or knockout, and whether they are administered in vivo or ex vivo. A comprehensive understanding of the patient journey is essential. Professionals should be able to summarize the key logistical steps and clinical responsibilities involved, such as blood cell collection procedures, centralized manufacturing processes, and patient conditioning protocols. They should also describe the unique complexity associated with the chemistry, manufacturing, and controls required for autologous cell therapies, emphasizing the importance of rigorous testing for critical quality attributes like cell viability and potency. Finally, ethical and regulatory considerations are vital. Healthcare providers should be able to define the distinction between somatic and germline gene therapy, explaining the associated ethical boundaries. They should understand the rationale behind the risk-based approach to long-term follow-up requirements mandated by regulatory agencies, ensuring patient safety and monitoring for potential adverse effects over time. The rapid development of cellular and genetic medicine has introduced a new class of therapeutics poised to revolutionize the management of a wide range of human diseases, from rare monogenic disorders to complex cancers. For healthcare professionals, understanding this landscape requires a clear grasp of the core principles, terms, and strategic differences that define these advanced treatment options. This section lays out the basic framework, distinguishing between cell therapy and gene therapy, clarifying their important relationship and outlining the main strategic approaches, in vivo and ex vivo, that guide their clinical use application. At the highest level, cell and gene therapies represent distinct but increasingly overlapping fields. A clear definition of each is essential before exploring their combined applications. Cell therapy is broadly defined as the administration of living cells to a patient for therapeutic purposes, with the aim of repairing, replacing, or enhancing a specific biological function. This category of therapy is distinguished by using cells as the active component. The source of these cells is a key differentiating factor. They can be autologous, meaning they are collected from the patient's own body, or allogeneic, meaning they are sourced from a healthy individual donor. The scope of cell therapy is broad, covering both long-established medical practices and the latest innovations. Traditional examples include blood transfusions and hematopoietic stem cell transplantation, commonly known as bone marrow transplant. This treatment has been a fundamental approach for many years in managing blood cancers and disorders resulting from bone marrow failure. Contemporary examples involve using various types of stem cells, such as mesenchymal stem cells, for regenerative medicine purposes. Additionally, the administration of activated immune cells is employed to fight disease. For example, the therapy known as Provenge, approved for prostate cancer, involves collecting a patient's immune cells, activating them outside the body against a tumor antigen, and then reintroducing them to stimulate an anti-cancer response. In all these cases, the cells themselves, whether modified or not, serve as the therapy. Gene therapy, on the other hand, is a molecular approach aimed at treating disease by altering or controlling gene expression. The main therapeutic agent is not a cell but a piece of genetic material, usually DNA or RNA, that is delivered as a biologic drug. Its primary goal is to address a problem at its genetic root. This can be done through various methods, such as replacing a faulty gene that causes disease, deactivating a malfunctioning gene, or introducing a new or modified gene to provide a therapeutic advantage. The U.S. Food and Drug Administration describes human gene therapy as a technique that seeks to change or regulate the expression of a gene or to modify the biological properties of living cells for therapeutic purposes. The distinction between cell and gene therapy becomes nuanced at their point of convergence. Gene-modified cell therapy. This powerful hybrid approach utilizes cells as a delivery vehicle for a gene-based therapeutic payload. It is officially classified as a subtype of cell therapy wherein cells are harvested from a patient, genetically altered in a laboratory setting, in vitro, and subsequently administered back to the patient. This process is also referred to as ex vivo gene therapy. The prime example of this integrated approach is chimeric antigen receptor, which is commonly abbreviated to CAR, T-cell therapy. In this method, a patient's T-cells, the cell therapy component, are collected through apheresis. These cells are then engineered using a viral vector to insert a new gene that encodes a CAR, the gene therapy component. This synthetic receptor allows the modified T-cells to identify and destroy cancer cells that display a specific surface antigen. Accepted therapies like Kymriah and Yescarta are groundbreaking treatments for B-cell cancers that rely on this principle. The convergence of these fields represents more than a semantic nuance. It indicates a new therapeutic approach. The most advanced treatments for conditions like sickle cell disease and various cancers are essentially integrated, requiring a multidisciplinary clinical approach that includes hematology, oncology, immunology, and molecular genetics. The logistical complexity of therapies like CAR-T, which involve apheresis, centralized manufacturing, cryopreservation, patient conditioning, and intensive monitoring, exists because it is both a cellular and a genetic product. Therefore, clinicians must understand how the cellular vehicle interacts with its genetic cargo to fully grasp these treatments. Gene therapy can be administered through two fundamentally different strategic approaches, defined by where the genetic modification of the target cells occurs, inside or outside the patient's body. In vivo, Latin for within the living, gene therapy involves the direct delivery of the therapeutic genetic material into the patient. The target cells are modified in their natural location within the body. The administration of the therapy can be carried out in different ways. It can be systemic, which involves delivering the therapeutic agent through an intravenous infusion. This method allows the vector to circulate throughout the entire body and reach the target organ, such as the liver. Alternatively, the therapy can be administered locally by directly injecting it into a specific tissue or anatomical compartment. Examples of local administration include injecting into the space beneath the retina of the eye or into a muscle. This approach helps concentrate the therapeutic effect on a targeted area and minimizes exposure to the rest of the body. The mechanism involves the use of a delivery vehicle, referred to as a vector, which is engineered to carry the therapeutic gene. This vector is most commonly a modified, non-pathogenic virus, such as an adeno-associated virus. The vector is administered to the patient where it travels to the target cells, enters them, and releases its genetic payload into the nucleus. Clinical applications of in vivo strategies are often the preferred and sometimes the only options for treating genetic disorders that affect internal organs or tissues that are difficult to access or cannot be practically removed, modified, or transplanted. These strategies are particularly relevant for organs such as the brain, heart, lungs, liver, and muscles. One example of an approved in vivo treatment is Luxturna, which is used for a rare inherited form of blindness. This medication is injected directly into the eye to deliver the therapeutic gene. Another example is Zolgensma, which is used for spinal muscular atrophy. This treatment is administered as a systemic intravenous infusion. These cases demonstrate the important role of in vivo gene therapy in managing complex genetic conditions that impact vital internal tissues and organs. Ex vivo, Latin for outside the living. Gene therapy is an indirect, multi-step process. It involves harvesting specific cells from the patient, modifying them genetically in a controlled laboratory environment, and then returning the engineered cells to the patient's body. As noted previously, this approach is synonymous with gene-modified cell therapy. The clinical workflow for this therapy is considerably more complex than that of in vivo treatment. It typically begins with the collection of the patient's cells, which are often hematopoietic stem cells or T lymphocytes, through a procedure known as apheresis. These cells are then sent to a specialized manufacturing facility where they are exposed to a vector, usually a lentivirus, that inserts the therapeutic gene into the cells. After this genetic modification, the cells may be expanded in number before being cryopreserved and shipped back to the original treatment center. Prior to reinfusion into the patient often undergoes a conditioning regimen, commonly involving chemotherapy, to deplete existing cells and create space for the new, modified cells to engraft and proliferate. Finally, the engineered cells are thawed and infused back into the patient through an intravenous line. Clinical applications of this strategy are most effective for diseases affecting tissues that are easily accessible and possess the ability to regenerate. This approach is primarily utilized for conditions involving the hematopoietic and immune systems. By modifying hematopoietic stem cells, which are the progenitors of all blood and immune cells, it becomes possible to repopulate the entire system with corrected cells. This makes the ex vivo method particularly suitable for treating genetic blood disorders such as sickle cell disease and beta thalassemia. Additionally, it is used for engineering immune cells and chimeric antigen receptor therapies for cancer. The choice between an in vivo or ex vivo strategy is not a matter of preference, but is fundamentally dictated by the biology of the target tissue and the nature of the disease. The accessibility and regenerative potential of the target cells are the primary determinants. Hematopoietic cells can be readily harvested from peripheral blood or bone marrow, modified externally, and returned to repopulate the system, making the ex vivo approach feasible and powerful for hematological conditions. In contrast, it is not practically possible to remove, modify, and replace the cells of a solid, non-regenerative organ like the brain or the retina. For these tissues, direct in vivo delivery is the only viable path. This biological constraint shapes the entire therapeutic development pipeline, influencing the choice of vector, the manufacturing logistics, the clinical administration protocol, and the associated risk profile for any given disease. A key distinction in gene therapy concerns the type of cells targeted, somatic cells or germline cells. This difference determines the scope and heritability of genetic changes and has significant ethical implications. In somatic gene therapy, the treatment targets the body's somatic cells. These are all cells except those of the reproductive system, such as sperm and eggs. The aim is to treat disease in a single individual. As a result, any genetic modifications are limited to that person and are not passed on to their children. This is the focus of all current basic research, clinical trials, and FDA-approved gene therapy products. The therapeutic effect is restricted to the treated individual, addressing their specific condition without changing the human gene pool. Germline gene therapy involves modifying germ cells, such as sperm, eggs, or early-stage embryos. Adding functional genes into the genome of these cells would create a heritable change, meaning the therapeutic modification could be passed down to all future generations. Although this method has the potential to permanently eliminate hereditary diseases from a family line, it faces significant technical and ethical challenges. These include concerns about unforeseen long-term effects on human development and evolution, the inability to obtain consent from future generations, and societal issues related to genetic enhancement. As a result, germline gene therapy is banned for use in humans in most countries worldwide. It is essential for healthcare professionals to understand this limit and to clearly inform patients that current, approved gene therapies are somatic and do not influence their children's genetic makeup. The success of any gene therapy depends on the safe and effective delivery of its therapeutic payload, the transgene, into the target cells. This is achieved using a delivery vehicle, or vector. The choice of vector is one of the most important decisions in developing gene therapy, as its biological features determine how the therapy is administered, how long it lasts, and the main safety concerns. The field employs both viral vectors, which are engineered from naturally occurring viruses, and non-viral systems, which are synthetically designed. Viruses have evolved over thousands of years to become highly specialized at entering host cells and delivering their genetic material. Gene therapy takes advantage of this natural ability by engineering viruses to act as therapeutic vectors. In this process, the viral genes responsible for replication and causing disease are removed and replaced with a therapeutic gene cassette. The resulting recombinant vector can still enter cells, but is made non-pathogenic and unable to replicate, making it a safe and effective delivery method. Adeno-associated virus has emerged as the leading vector platform for in vivo gene therapy, valued for its strong safety profile and versatility. The adeno-associated virus is a small, non-enveloped parvovirus measuring approximately 25 nanometers in diameter. It is not known to cause any disease in humans. For therapeutic applications, recombinant versions are engineered to carry a therapeutic gene expression cassette, which is flanked by two inverted terminal repeats of the virus. When the virus enters the target cell nucleus, its single-stranded DNA genome is converted into a double-stranded, circular DNA molecule known as an apisome. This apisome resides within the nucleus, separate from the host cell's chromosomes, and functions as a stable template for the long-term transcription of the therapeutic gene. Since the adeno-associated virus typically does not integrate its genome into the host chromosomes, it has a very low risk of causing insertional mutagenesis, which provides a significant safety advantage. The advantages of the adeno-associated virus as a viral vector platform include its safety profile, broad tissue targeting ability, and durable gene expression. Due to its non-pathogenic nature and low likelihood of integrating its genetic material into the host genome, it is considered one of the safest viral vectors available. This virus can effectively infect both dividing and non-dividing cells, making it suitable for targeting tissues such as neurons, retinal cells, and muscle cells, which are often postmitotic. Additionally, the genome of the virus exists in an episomal form that remains highly stable in non-dividing cells. This stability enables sustained expression of the inserted gene for many years, potentially lasting a lifetime, after a single administration. Serotype diversity refers to the wide variety of naturally occurring and engineered adeno-associated virus types. Examples of these types include adeno-associated virus 1, 2, 5, 8, and 9. Each of these virus types has a unique protein capsid that determines its preference for infecting specific tissues. This allows researchers to select a particular virus type to target an organ of interest more effectively. For instance, the virus type that selectively targets the liver is adeno-associated virus 8, while the one that targets muscle tissue is adeno-associated virus 1. The virus type that can cross into the central nervous system is adeno-associated virus 9. Limitations of using adeno-associated virus in gene therapy include its limited packaging capacity, which is approximately 4.7 kilobases. This restriction prevents the virus from delivering larger genes, such as the full-length dystrophin gene of about 14 kilobases, which is necessary for treating Duchenne muscular dystrophy. Another challenge is pre-existing immunity. Since adeno-associated virus is a common virus, a significant portion of the human population, ranging from 40% to more than 70% depending on the serotype, has neutralizing antibodies from prior natural infection. These antibodies can bind to and deactivate the virus vector upon administration, rendering the therapy ineffective. Therefore, patients need to be screened for these antibodies before treatment, and those with high antibody titers are often deemed ineligible. Despite being considered to elicit a low immune response, adeno-associated virus vectors can still provoke immunogenicity, especially at the high doses required for systemic administration. This immune response can involve cytotoxic T-cell activation against transduced cells, which may lead to a loss of therapeutic effect over time. Additionally, high doses can cause liver toxicity, characterized by elevated serum transaminase levels. Furthermore, administering an adeno-associated virus vector usually triggers a strong antibody response that prevents readministration using the same viral serotype. Lentiviral vectors, which originate from the retrovirus family, serve as the foundation of ex vivo gene therapy due to their unique capability to permanently insert a therapeutic gene into the genome of a host cell. Most lentiviral vectors used in clinical settings are derived from the human immunodeficiency virus type 1. Modern third-generation lentiviral vectors incorporate numerous safety features to minimize risks. The genes necessary for producing the vector are divided across multiple separate plasmids, which enhances safety by preventing the formation of replication-competent viruses. Additionally, essential viral components, such as the envelope gene, are supplied on a separate plasmid, often from a different virus through a technique called pseudotyping, to expand the range of cell types that can be targeted and to improve safety. The viral RNA genome, along with the enzyme reverse transcriptase, is packaged into the vector particle. When the vector transduces a target cell, the reverse transcriptase enzyme converts the viral RNA into double-stranded DNA. This DNA is then transported into the nucleus, where it is permanently integrated into the host cell's chromosome by the viral enzyme integrase. The resulting integrated DNA, known as a provirus, becomes a stable part of the genetic material of the cell and is transmitted to daughter cells during cell division. The advantages of lentiviral vectors include stable integration into the host genome. This feature is particularly important for therapies targeting dividing cell populations such as hematopoietic stem cells, as it ensures that the therapeutic gene is maintained and propagated throughout the entire cell lineage. Additionally, lentiviral vectors can carry significantly larger genetic payloads compared to adeno-associated viruses, with a capacity of approximately 9 kilobases. This allows for the delivery of larger or more complex gene cassettes, including those containing multiple genes or sophisticated regulatory elements. Furthermore, lentiviral vectors can efficiently transduce both dividing and non-dividing cells. Although their primary clinical utility is in modifying dividing stem cells. The most significant safety concern associated with lentiviral vectors is insertional mutagenesis. This occurs because the integration of the genetic material into the host genome is semi-random. If the vector integrates near a proto-oncogene, it can cause overexpression of that gene, potentially leading to malignant transformation. Conversely, integration within a tumor suppressor gene may result in its inactivation. This risk became evident in early clinical trials involving related gamma-retroviral vectors used for treating X-linked severe combined immunodeficiency. Several patients developed leukemia years after treatment due to activation of an oncogene by the vector. To address this concern, modern lentiviral vectors are engineered with self-inactivating long terminal repeats, which eliminate promoter activity in these regions after insertion. This modification reduces the likelihood of activating nearby genes. Lentiviral vectors are primarily used in ex vivo settings because of the associated risks. In such applications, the target cells are transduced outside the body and then carefully characterized and tested for safety in the laboratory before being reintroduced into the patient. This approach provides a critical level of control that is not feasible with direct application inside the body, thereby helping to minimize the potential for adverse effects resulting from insertional mutagenesis. The fundamental biological differences between adeno-associated virus vectors and lentiviral vectors result in their distinct therapeutic applications. Adeno-associated virus vectors are characterized by their episomal nature and a strong safety profile, making them the preferred choice for direct in vivo administration to correct defects in stable, non-dividing tissues. Conversely, lentiviral vectors have the ability to permanently integrate their genetic payload into the host genome. This feature makes them indispensable for ex vivo modification of stem cells, where the genetic correction needs to be inherited by subsequent generations of daughter cells. The inherent biology of these vectors does not merely influence how the therapy is delivered, but also shapes the entire therapeutic strategy. This includes the method of administration and the long-term risk-benefit profile of the treatment. While viral vectors are highly efficient, their potential for immunogenicity, limited packaging capacity, and complex manufacturing have driven the development of non-viral alternatives. These synthetic systems aim to provide a safer, more customizable, and more scalable approach to gene delivery. The simplest non-viral vector is naked plasmid DNA, which involves administering a circular, double-stranded DNA molecule. This DNA is engineered in bacteria to include the therapeutic gene along with the necessary regulatory elements to enable expression in human cells. One of the main advantages of this approach is that plasmid DNA is relatively straightforward and inexpensive to produce in large quantities. Additionally, it has a very low immunogenicity profile, meaning the body typically does not mount an immune response against the DNA itself. This allows for safe readministration. Furthermore, because the plasmid DNA does not integrate into the genome, it avoids the risk of insertional mutagenesis, which could otherwise lead to genetic mutations. The main disadvantage of naked pDNA is its very low transfection efficiency. When injected, the plasmid must pass through several tough biological barriers, including degradation by nucleases in the bloodstream and outside the cells, poor uptake across the cell membrane, and failure to reach the nucleus. As a result, the levels of gene expression are often too low to be useful therapeutically. To address this, physical delivery methods such as electroporation, using electrical pulses to temporarily open cell membranes, or synoperation, using ultrasound and microbubbles, are often used to improve cellular uptake, especially in accessible tissues like muscle or skin. The success of messenger RNA vaccines against COVID-19 has propelled messenger RNA and lipid nanoparticle technology to the forefront of nucleic acid therapeutics. This system utilizes a synthetically produced messenger RNA molecule as the therapeutic payload, which is encapsulated within a lipid nanoparticle for delivery. The lipid nanoparticle is a multi-component lipid sphere that typically contains an ionizable lipid, a helper lipid, cholesterol, and a polyethylene glycosylated lipid. This formulation protects the fragile messenger RNA molecule from degradation by ribonucleases in the body and facilitates its uptake into target cells through an endocytosis process. Once inside the cell's endosome, the ionizable lipid becomes positively charged in the acidic environment. This change disrupts the endosomal membrane, releasing the messenger RNA into the cytoplasm. The cell's ribosomes then translate the messenger RNA to produce the desired therapeutic protein. Importantly, the messenger RNA never enters the cell nucleus and does not interact with the host genome, thereby avoiding any risk of genomic integration or insertional mutagenesis. Advantages of mRNA-based therapies include its safety profile, as the non-integrating nature of messenger RNA reduces the risk of genetic damage. The effects of these therapies are temporary because the messenger RNA and the proteins it encodes are naturally broken down by the cells within a few hours to days. This characteristic is beneficial in situations where long-term gene expression might be harmful or unwanted, as it also allows for the treatment to be halted if adverse effects arise. Additionally, the manufacturing process for messenger RNA therapies is both fast and scalable, involving a cell-free system. This method is independent of the specific genetic sequence being produced, enabling the rapid development and production of new therapeutic agents compared to traditional viral vector techniques. The limitations of current technologies include issues related to durability, immunogenicity or toxicity, and targeting. Because expression is transient, treating chronic diseases with these methods would require repeated administrations, which can be inconvenient and costly. Additionally, both the messenger RNA molecules and the lipid nanoparticle components can provoke inflammatory responses and activate innate immune mechanisms, which might be undesirable for therapeutic applications beyond vaccines. Another significant challenge is targeted delivery. Present lipid nanoparticle formulations are mainly absorbed by the liver after systemic administration, and achieving efficient and specific delivery to tissues outside the liver remains a major area of ongoing research and development. Antisense oligonucleotides are short, single-stranded synthetic molecules of nucleic acids, typically measuring between 12 and 25 nucleotides in length. These molecules are chemically modified to resist degradation and are designed to be perfectly complementary to a specific target RNA sequence within the cell. These molecules function as agents that can modify RNA. By binding to their target RNA through Watson-Crick base pairing, they can influence protein expression in several different ways. One common mechanism involves recruiting an endogenous enzyme called ribonuclease H, which recognizes the DNA-RNA hybrid formed and cleaves the target messenger RNA, leading to its degradation and thereby preventing the production of proteins. Alternatively, antisense oligonucleotides can be designed to physically block the ribosome from translating messenger RNA, or more intricately, to bind to a precursor messenger RNA molecule and modulate its splicing. This modulation can be used to make the cell's splicing machinery skip over a mutated, disease-causing exon or to promote the inclusion of an essential exon that is normally excluded. Antisense oligonucleotides offer high specificity for their target RNA, enabling therapeutic outcomes that are difficult to achieve with other approaches. Their synthetic nature allows for extensive chemical modifications, which enhance their stability, binding affinity, and pharmacokinetic properties. However, the therapeutic effects of antisense oligonucleotides are transient, similar to messenger RNA, which necessitates repeated and often lifelong administration. Delivering these molecules to tissues outside of the liver and central nervous system is challenging, as they can be administered directly into the cerebrospinal fluid. Despite their high specificity, there is a potential for off-target binding to unintended RNA sequences, which can lead to toxicity. The increasing diversity of these delivery systems reflects a strategic divergence in the field. Adeno-associated virus and LV-based therapies mainly pursue a one-and-done approach, aiming for a permanent or long-lasting cure with a single administration. This method has the potential to be transformative, but also carries risks of irreversibility and long-term, unknown effects. Conversely, the RNA-based platforms, mRNA and ASOs, follow a more traditional, drug-like model. They provide temporary, controllable effects that require ongoing treatment. This approach might be safer and more adaptable, as therapy can be modified or stopped, but it sacrifices the possibility of a one-time cure. Choosing between permanent and transient intervention introduces a new set of clinical ethical, and economic considerations for physicians, patients, and healthcare systems. Beyond the delivery method, the core of gene therapy focuses on the therapeutic payload and its intended mechanism of action at the molecular level. The strategy for genetic manipulation is selected based on the underlying disease process. There are three main approaches: replacing genes in cases of loss-of-function disorders, silencing or deleting genes in cases of gain-of-function disorders, and adding or inserting genes for precise genetic correction. Gene replacement, also called gene addition, is the most typical approach in gene therapy. It aims to treat diseases caused by mutations that result in loss of function. These are conditions where a specific gene is either missing or mutated in such a way that it does not produce enough functional protein. The approach involves delivering a healthy and functional copy of the affected gene, known as the transgene, into the patient's target cells. This new gene does not replace the faulty gene in the chromosome. Instead, it coexists with it. In the case of adeno-associated virus vectors, the transgene typically exists as an apisome, while with lentiviral vectors, it is usually an additional integrated copy. Once inside the cell, the transgene provides the correct genetic instructions necessary for the cellular machinery to produce the missing or defective protein. As a result, this process restores the normal function of the cell and helps alleviate the symptoms of the disease. The clinical applications of this strategy serve as the foundation for treating a wide spectrum of classic, single-gene inherited disorders. Its clinical utility is directly related to the ability to restore protein function. For instance, Luxturna, or Veretagene Nepervovec RZYL, is used to treat Leber congenital amaurosis, a form of inherited blindness caused by mutations in the RPE65 gene. This therapy employs an adeno-associated virus vector to deliver a correct copy of the RPE65 gene to retinal cells, restoring their capacity to produce an enzyme essential for vision. Similarly, Zolgensma, or Onisimnogene abeparvovec ZIOI, is used to treat spinal muscular atrophy, a severe neuromuscular disorder caused by the loss of the survival motor neuron 1 gene. This treatment uses an adeno-associated virus type 9 vector to deliver a functional copy of the gene to motor neurons, enabling the production of the protein necessary for their survival and proper function. Treatments for hemophilia, such as Roctavian and Hemgenix, address the deficiency of clotting factors. Hemophilia A and B are caused by mutations in the genes responsible for clotting factors 8 and 9, respectively. These therapies utilize adeno-associated virus vectors to deliver functional copies of the relevant genes to liver cells, effectively transforming them into factories that produce and secrete the missing proteins into the bloodstream. The process of selecting a gene replacement strategy depends heavily on an accurate molecular diagnosis. It is essential for the clinician to confirm that the disease is caused by a loss of protein function. For instance, in a patient with cystic fibrosis, the disease is characterized by a non-functional cystic fibrosis transmembrane conductance regulator protein. Such a patient would typically be considered a candidate for a gene replacement therapy aimed at providing a functional copy of this gene. This direct correlation between the underlying molecular defect and the therapeutic approach highlights the importance of incorporating genetic diagnostics into the clinical evaluation process for these types of treatments. Gene silencing and gene deletion, also known as gene knockout, are methods used to inactivate problematic genes. Unlike disorders caused by loss of function, some genetic diseases result from a toxic gain of function, where a mutated gene produces an abnormal and harmful protein. In other cases, the overproduction of a normal protein can also lead to disease. For these types of conditions, the therapeutic goal is not to add a gene, but to deactivate or eliminate the problematic gene. This can be accomplished either through temporary gene silencing techniques or by permanently deleting the gene altogether, a process known as gene knockout. The mechanism of gene silencing, also known as gene knockdown, involves reducing or eliminating the expression of a specific gene at the RNA level without altering the underlying DNA sequence. This approach is primarily utilized by RNA-based therapeutics such as antisense oligonucleotides and small interfering RNAs. These therapeutic molecules are designed to bind specifically to messenger RNA transcribed from the target gene. When this binding occurs, it can either trigger the degradation of the messenger RNA by cellular enzymes like RNase H or physically obstruct the ribosome from translating the messenger RNA into protein. As a result, there is a significant decrease in the production of the pathogenic protein associated with the gene. Gene deletion, knockout, is a permanent approach that uses gene editing tools, such as CRISPR/Cas9 or zinc finger nucleases, ZFNs, to directly and irreversibly disable a gene at the DNA level. These tools are guided to a specific location in the genome where they create a double-strand break, DSB, in the DNA. The cell's primary repair mechanism for such breaks is a process called non-homologous end joining, NCJ, which is fast but error-prone. NCJ often introduces small insertions or deletions of DNA base pairs, collectively known as indels, at the site of the break. If these indels occur within the coding sequence of a gene, they typically cause a frameshift mutation, which alters the reading frame of the gene and leads to the creation of a premature stop codon. This effectively knocks out the gene, permanently preventing the production of a full-length, functional protein. Clinical applications of gene therapy include treatments for several serious diseases. One investigational approach targets transthyretin amyloidosis, a condition caused by the accumulation of misfolded transthyretin protein. This therapy utilizes lipid nanoparticles to deliver CRISPR/Cas9 components to the liver, aiming to disable the transthyretin gene in liver cells. By doing so, it significantly reduces the production of the toxic protein at its source. Another application involves Huntington's disease, a neurodegenerative disorder caused by a harmful mutant huntingtin protein. Several experimental treatments use antisense oligonucleotides or small interfering RNAs to silence the expression of the mutated gene responsible for this protein, potentially slowing disease progression. A third example is the treatment of sickle cell disease. The already approved therapy involves a gene knockout strategy that employs CRISPR/Cas9 to disable the BCL11A gene in a patient's hematopoietic stem cells. This gene typically represses the production of fetal hemoglobin after birth. Knocking out this gene reactivates fetal hemoglobin production, which does not sickle and can compensate for the abnormal adult hemoglobin. As a result, this treatment offers a promising approach for managing sickle cell disease. The most precise and technically challenging form of genetic manipulation is gene knock-in. This approach goes beyond simply adding a gene randomly or knocking one out. It aims to make a precise change at a specific location in the genome. This can involve correcting a disease-causing mutation back to the normal sequence or inserting an entire therapeutic gene into a predetermined, safe genomic location known as a safe harbor locus. Gene knock-in relies on the same gene editing tools, e.g., CRISPR/Cas9, used for knockout to create a targeted DSB. However, in addition to the nuclease and guide RNA, a donor or repair DNA template is also delivered to the cell. This template contains the desired new genetic sequence, e.g., the corrected version of a gene or a new therapeutic gene, flanked by sequences that are homologous, identical, to the DNA on either side of the DSB. The cell can then use a more precise but less efficient repair pathway called homology-directed repair, HDR. In HDR, the cell uses the provided donor template to repair the break, perfectly pasting the new genetic information into the target site in the genome. While gene knock-in represents the ultimate goal of gene editing, true gene correction, its reliance on the inefficient HDR pathway has made it more difficult to achieve in a clinical setting compared to NCJ-mediated knockout. Research is actively exploring true knock-in strategies for diseases like beta thalassemia and sickle cell disease, where the goal is to insert a correct copy of the beta-globin gene directly into its natural location in the genome or into a safe harbor locus like APOC3 or AVS1 within hematopoietic stem cells. Advanced CAR-T strategies are being developed that use knock-in techniques to insert the CAR gene into a specific locus in the T-cell genome, such as the TRAC locus. This can lead to more uniform and controlled expression of the CAR, potentially improving efficacy and reducing toxicity compared to the random integration provided by lentiviral vectors. These three manipulation strategies represent a spectrum of increasing technical complexity and precision. Gene replacement is the most established, but offers the least control over the location of the new gene. Gene knockout provides precise targeting for inactivation, but relies on an error-prone cellular repair process. Gene knock-in offers the highest level of precision and control, true gene surgery, but is the most technically demanding due to the low efficiency of the HDR pathway. The current landscape of approved therapies reflects this hierarchy. Most are gene replacement therapies. The most recent approvals are sophisticated gene knockouts, and true knock-in therapies are still largely in earlier stages of clinical development. This progression illustrates the field's evolution toward greater genomic precision, a trend that promises to unlock new therapeutic possibilities while simultaneously presenting new technical and safety challenges. The theoretical principles and molecular tools of gene and cell therapy have led to the development of an increasing number of tangible products that have received approval from the Food and Drug Administration and are now incorporated into clinical practice. Analyzing these approved therapies reveals distinct patterns in their application, with specific technologies being matched to particular categories of disease. In therapies administered directly into the patient's body, the focus has been primarily on rare, monogenic diseases. These are conditions caused by mutations in a single gene, where replacing that gene can result in significant therapeutic benefits. In this category, one of the most commonly used platforms involves vectors based on a type of virus known as the adeno-associated virus. The therapies listed in the table highlight a clear strategic pattern: the use of adeno-associated virus vectors for simple gene replacement in static, post-mitotic tissues. Zolgensma, onasimnogene abeparvovec, is used to treat spinal muscular atrophy, SMA. It functions as a gene replacement therapy, delivering a functional copy of the SMN1 gene to motor neurons using an adeno-associated virus serotype 9, AV9, vector. Luxturna, voretigene nepervovec RZYL, addresses inherited retinal dystrophy caused by RPE65 mutations. This gene replacement therapy delivers a functional RPE65 gene to retinal cells via subretinal injection, utilizing an adeno-associated virus serotype 2, AV2, vector. For severe hemophilia A, Roctavian, volocticogene roxaparvovec provides gene replacement by delivering a functional factor 8, F8, gene to liver cells, employing an adeno-associated virus serotype 5, AV5, vector. Similarly, Hemgenix, etranacogene dasaparvovec Durel B, treats hemophilia B through gene replacement, delivering a functional factor 9, F9, gene to liver cells, also using an adeno-associated virus serotype 5, AV5, vector. Elevidys, delandistrogene moxeparvovec is indicated for Duchenne muscular dystrophy, DMD. It delivers a gene encoding a truncated, functional version of dystrophin, microdystrophin, to muscle cells via an AV vector. In the case of dystrophic epidermolysis bullosa, DEB, Vyjuvek, barimagene geperpavec acts as a gene replacement therapy. It's a topical gel that delivers a functional copy of the COL7A1 gene to wound cells using a herpes simplex virus type 1, HSV1 vector. Finally, adstiladrin, nadofaragene furatinovec VCNG, targets high-risk non-muscle invasive bladder cancer. It delivers a gene encoding interferon alpha, 2B directly to bladder cells through intravesical instillation, stimulating an anti-tumor immune response with an adenovirus vector. Adeno-associated virus vectors are commonly used for straightforward gene replacement therapies, particularly in tissues that do not divide, such as nerve cells, retinal cells, and liver cells. These therapeutic approaches offer lasting, long-term benefits following a single administration. By targeting static, post-mitotic tissues, these treatments can provide durable results without the need for repeated interventions. The ex vivo approach, where a patient's cells are engineered outside the body, has transformed the treatment of blood cancers and inherited blood disorders. This method mainly involves two cell types: immune T cells, for CAR-T therapy, and hematopoietic stem cells. The primary tool for genetic modification in this process is the lentiviral vector, valued for its ability to permanently insert the therapeutic gene into the genome of dividing cells. The success of ex vivo therapies highlights a different strategic approach. In cancer treatment, CAR-T therapies do not fix a genetic defect, but instead create a living drug by arming a patient's immune cells to attack their cancer. For inherited blood disorders, editing the patient's own HSCs offers a lasting, autologous supply of corrected blood cells, effectively curing the disease without needing an allogeneic donor and reducing risks like graft versus host disease. The recent approval of 2 different therapies for sickle cell disease, Lyfgenia, a lentiviral gene addition, and Casgevy, a CRISPR-based gene knockout, marks a significant milestone, confirming both traditional gene therapy and advanced gene editing as potent clinical options. This clear division of disease targets between the 2 methods reflects the strengths of their underlying technologies. In vivo adeno-associated virus therapy is ideal for simple gene replacement in specific, isolated tissues. The ex vivo lentiviral approach, on the other hand, is uniquely capable of reprogramming the entire hematopoietic system, making it essential for complex blood disorders and powerful cellular immunotherapies. The current approved products represent the first wave of these technologies, mostly targeting the easiest diseases, monogenic disorders with a clear loss of function and liquid tumors with specific surface antigens like CD19 and BCMA. The pipeline ahead aims at more challenging goals, including developing CAR-T therapies for solid tumors, applying gene editing to a broader range of genetic diseases, and creating vectors to target new organs. This suggests that the full clinical reach of these platforms is still on the horizon. To provide a complete clinical context, it is important to recognize cell therapies that do not involve genetic modification. These treatments leverage the natural biological properties of cells. Provenge, Sipusel-T, is an autologous cellular immunotherapy used to treat prostate cancer. The process involves collecting a patient's peripheral blood mononuclear cells, which include antigen-presenting cells, and culturing them outside the body. During this ex vivo culture, these cells are exposed to a recombinant fusion protein. This protein consists of prostatic acid phosphatase, a prostate tumor antigen, and an immune stimulatory cytokine. The activated antigen-presenting cells are then rain-fused into the patient. This rain fusion stimulates a T-cell immune response specifically targeting prostate cancer cells that express prostatic acid phosphatase. It is important to note that this therapy does not involve any genetic modification. MACI, autologous cultured chondrocyte on a porcine collagen membrane, a regenerative medicine product for repairing cartilage defects in the knee. A sample of a patient's healthy cartilage cells, chondrocyte, is harvested, expanded in number in a laboratory, and then seeded onto a collagen membrane. This cell-seeded membrane is then surgically implanted into the cartilage defect, where the cells can generate new, healthy cartilage tissue. These examples underscore that the therapeutic use of cells is a broad field, with gene-modified cell therapy representing its most technologically advanced frontier. MACI, autologous cultured chondrocyte on a porcine collagen membrane, is a regenerative medicine product used to repair cartilage defects in the knee. The process involves harvesting a sample of a patient's healthy cartilage cells, known as chondrocyte. These cells are then expanded in number in a laboratory and subsequently seeded onto a collagen membrane. This cell-seeded membrane is surgically implanted into the cartilage defect, where the cells are able to generate new, healthy cartilage tissue. These examples highlight that the therapeutic use of cells is a broad field, with gene-modified cell therapy representing its most technologically advanced frontier. The translation of gene and cell therapies from a scientific concept into a clinical reality involves a highly complex and resource-intensive life cycle. Unlike conventional pharmaceuticals that can be mass-produced and prescribed, many of these treatments, particularly autologous ex vivo therapies, are personalized medical procedures. The process encompasses an extended patient journey, from initial consultation to long-term post-treatment monitoring, and relies on exceptionally rigorous chemistry, manufacturing, and controls (CMC) to ensure the safety and efficacy of each unique therapeutic batch. The administration of a gene therapy is not a single event, but a protracted process that can span many months and requires a high degree of coordination between the patient, their primary care team, and a specialized treatment center. The journey begins with a comprehensive consultation at a qualified treatment center. During this phase, the clinical team discusses the potential risks, benefits, and available alternatives with the patient and their family to facilitate informed consent. Eligibility screening is a critical step. For all gene therapies, this includes genetic testing to confirm the specific mutation that the therapy targets. For therapies using adeno-associated virus vectors, patients must undergo serological testing to screen for pre-existing neutralizing antibodies, NAbs, against the specific adeno-associated virus serotype being used. A high NAb titer would likely render the therapy ineffective and is a common exclusion criterion. Once a patient is deemed eligible and consents to treatment, the preparation phase begins. For ex vivo therapies, this involves the collection of the patient's own cells. This is typically done through a pharmacist, a procedure where blood is drawn from the patient, passed through a machine that separates out the desired cell type, e.g., T cells or hematopoietic stem cells, and the remaining blood is returned to the body. This process can take several hours. For in vivo therapies, the patient may need to start a pre-treatment regimen of immunosuppressive drugs, such as corticosteroids. This is done to temporarily dampen the immune system to prevent it from mounting a strong response against the incoming viral vector, thereby increasing the therapy's chances of success. Following apheresis, the collected cells are cryopreserved and shipped to a centralized, highly specialized good manufacturing practice, GMP, facility. Here, the complex process of genetic modification takes place. The cells are thawed, transduced with the viral vector carrying the therapeutic gene, and often expanded in culture to reach the required therapeutic dose. This entire manufacturing process is highly regulated and can take anywhere from several weeks to several months to complete. During this time, the patient is typically at home, awaiting the completion of their personalized drug product. This logistical chain represents a significant bottleneck and a key difference from off-the-shelf pharmaceuticals. Once the gene-modified cell product is ready, the patient is admitted to the hospital to begin the conditioning phase. This involves the administration of high-dose, myeloablative chemotherapy. The purpose of conditioning is to eliminate the patient's existing, diseased bone marrow cells to create physical space and a favorable environment for the newly engineered HSCs to engraft, proliferate, and repopulate the hematopoietic system. This step is associated with significant toxicities, including profound immunosuppression and a high risk of infection. The final therapeutic product is delivered to the patient. For ex vivo therapies, the cryopreserved, gene-modified cells are carefully thawed at the patient's bedside and infused intravenously over a short period. In vivo therapies involve administering the vector as a one-time intravenous infusion or a local injection into the target tissue, such as the eye or spine. Following the infusion, patients are monitored closely for immediate and short-term adverse events. For ex vivo HSC therapies, this involves a prolonged hospital stay of several weeks, often in a specialized transplant unit. During this time, the patient has little to no immune function and requires intensive supportive care while awaiting engraftment, the process by which the infused stem cells take hold in the bone marrow and begin producing new, healthy blood cells. For CAR-T therapies, monitoring is focused on two unique and potentially life-threatening toxicities: cytokine release syndrome, CRS, a systemic inflammatory response caused by the massive activation of the engineered T cells, and immune effector cell-associated neurotoxicity syndrome, ICANS. For in vivo adeno-associated virus therapies, particularly those administered systemically, monitoring focuses on liver function, as dose-dependent hepatotoxicity is a known risk. The patient's journey does not end upon discharge from the hospital. Because gene therapies are designed to be permanent or long-acting, regulatory agencies mandate long-term follow-up to monitor the durability of the therapeutic effect and to surveil for any delayed adverse events, such as secondary malignancies. This follow-up can last for up to 15 years and involves regular clinical visits and laboratory tests. This intricate and lengthy patient journey underscores the immense logistical and infrastructural burden of gene and cell therapies. They require highly specialized treatment centers with multidisciplinary teams, e.g., hematology, oncology, neurology, intensive care, pharmacy, and sophisticated infrastructure for cell collection, processing, and patient monitoring. This complexity creates significant barriers to patient access and distinguishes these treatments as comprehensive medical procedures rather than simple prescriptions. For conventional drugs, the product is a well-defined chemical entity. For cell and gene therapies, the product is a complex biological system. This complexity necessitates an exceptionally stringent regulatory framework for chemistry, manufacturing, and controls, CMC, to ensure that every dose is safe, effective, and consistent. This is particularly true for autologous therapies, where the manufacturing process itself is an integral part of the product, a concept often referred to as the process is the product. Even minor variations in the manufacturing process can have a significant impact on the final product's quality and clinical performance. The FDA provides detailed guidance on the CMC information required for an investigational new drug, IND, application for a gene therapy product. The focus is on ensuring the product's safety, identity, strength, purity, and quality, SGSPQ, through rigorous control of all aspects of manufacturing. Every component used in the manufacturing process must undergo meticulous sourcing, qualification, and testing. This includes vectors, cells, and reagents and excipients. The vector construct needs to be fully characterized, including the sequence of the gene insert and all regulatory elements. The cell line used to produce the vector, known as the producer cell line, must be thoroughly documented and tested. For autologous products, the collection and handling of the patient's source cells must be standardized. In the case of allogeneic products, the donor must be rigorously screened for communicable diseases, and both the master and working cell banks must be extensively characterized. All ancillary materials, such as cell culture media, cytokines, and final formulation buffers, must be of an appropriate grade and quality. Methods must also be in place to demonstrate the clearance of process reagents that are not intended to be present in the final product. The entire manufacturing process must be described in detail, with well-defined steps and in-process controls to ensure consistency. This includes cell isolation and selection, gene modification, transduction, cell expansion, harvesting, purification, and final formulation and cryopreservation. For autologous products, where each patient's cells constitute a unique manufacturing batch, maintaining process consistency is a monumental challenge. Before a batch of gene therapy can be released for clinical use, it must undergo a rigorous and comprehensive panel of tests. These tests are crucial to ensure that the product consistently meets predefined specifications for several critical quality attributes, guaranteeing both its safety and efficacy for patients. Identity, a fundamental critical quality attribute, confirms that the gene therapy product contains precisely the correct genetically modified cells or vector. Verification methods are highly specific and often include flow cytometry, which is used to detect specific cell surface markers characteristic of the genetically modified cells, confirming their presence and identity. Polymerase chain reaction is also employed to detect the transgene, the therapeutic gene inserted into the cells or vector. This molecular method confirms the successful genetic modification at the DNA level. Assessing purity is vital to ensure the absence of harmful contaminants. A comprehensive purity panel includes tests for microbial contamination, which involves testing for sterility, absence of bacteria and fungi, and mycoplasma, a common and difficult-to-detect bacterial contaminant that can severely impact cell cultures and patient safety. Endotoxins, which are toxic components of bacterial cell walls that can cause fever and other adverse reactions in patients, are also tested. Endotoxin testing is a critical safety measure. Process-related impurities, including residual host cell proteins and host cell deoxyribonucleic acid from the cells used to produce the vector, as well as components from the vector production process itself, are also assessed. High levels of these impurities can elicit immune responses or have other detrimental effects. For viral vectors, a particularly important purity test is for replication-competent virus. This ensures that no infectious, replicating virus was inadvertently generated during the manufacturing process, which could lead to uncontrolled viral spread in the patient. Strength, dose, quantifies the active substance in the gene therapy product, ensuring that patients receive the intended therapeutic dose. The measurement varies depending on the product type. For viral or non-viral vector products, strength is often measured as the titer, the concentration of infectious or transducing particles, or the number of vector genomes per milliliter, indicating the amount of genetic material delivered. For cell-based gene therapies, strength is determined by the total number of viable cells, reflecting the total therapeutic cellular material. Additionally, it often includes the percentage of those cells that have been successfully genetically modified, directly correlating with the active therapeutic component. Specifically for cell-based products, viability testing is crucial. This test ensures that a sufficient percentage of the cells remain alive and functional after the manufacturing process and subsequent thawing, if stored frozen. Viability directly impacts the efficacy of the cell therapy, as dead or non-functional cells cannot exert their therapeutic effect. The Food and Drug Administration generally recommends a minimum viability of 70% for cell-based products to ensure a potent and effective dose. Potency, often regarded as the most critical and challenging release test, is a biological assay that directly measures the specific therapeutic function of the gene therapy product. It is a cornerstone of demonstrating efficacy and must be quantitative, meaning the assay must provide a measurable numerical result, allowing for consistent evaluation and comparison between batches. It must also be reflective of the product's mechanism of action. The potency assay must accurately mimic or directly measure how the gene therapy is expected to work in the body. For example, for a chimeric antigen receptor T-cell product, a potency assay might measure its ability to recognize and specifically kill target cancer cells in vitro in a lab setting, directly reflecting its anti-cancer mechanism of action. For a gene therapy designed to produce a missing protein, the potency assay might measure the expression level or functional activity of that protein. Developing a robust, reliable, and clinically relevant potency assay is a major focus and often a rate-limiting step in the chemistry, manufacturing, and controls development of any gene therapy product. Its successful establishment is paramount for regulatory approval and ensuring patient benefit. The immense challenge of CMC for autologous therapies is a primary driver of their high cost and a potential point of failure in the patient journey. Each patient's cells represent a batch of one, requiring the entire suite of manufacturing and quality control processes to be executed individually. This personalized manufacturing paradigm is the Achilles heel of the field, creating bottlenecks, driving costs, and leading to occasional manufacturing failures where a viable product cannot be made for a patient who has already undergone preparatory procedures. This reality is fueling a significant research effort toward developing allogeneic, off-the-shelf, cell therapies from healthy donor cells, which could be manufactured in large, uniform batches, more closely resembling the traditional pharmaceutical model. While gene and cell therapies offer unprecedented therapeutic potential, their clinical implementation is accompanied by unique and significant challenges related to safety, regulation, and long-term outcomes. Understanding these considerations is paramount for clinicians managing patients undergoing these treatments. This final section addresses the key safety risks, the regulatory framework designed to mitigate them, and the future trajectory of this rapidly advancing field. The safety profile of a gene therapy is intrinsically linked to its components: the vector, the transgene, and the target cells, and the mechanism of genetic manipulation. The human immune system is exquisitely evolved to recognize and eliminate foreign materials, posing a major challenge for gene therapies. This is a primary concern for in vivo therapies that utilize viral vectors, such as adeno-associated virus, AAV. Many individuals possess pre-existing neutralizing antibodies, NAbs, from natural exposure to wild-type viruses. These antibodies can inactivate the therapeutic vector before it reaches its target cells. Even if a patient is NAb-negative at baseline, the administration of the vector itself can trigger a potent immune response. This can include a humoral antibody response, which prevents any future redosing with the same vector. Additionally, a cellular T-cell response can occur where cytotoxic T lymphocytes recognize and destroy the transduced cells, leading to a loss of long-term therapeutic expression. In patients with null mutations who have never produced the therapeutic protein, their immune system may recognize the newly expressed protein as foreign and mount an immune response against it, neutralizing its effect. Ex vivo cell therapies present their own distinct immunological risks. Cytokine release syndrome, CRS, is a systemic inflammatory response observed in chimeric antigen receptor, CAR, T-cell therapy. It is caused by the rapid activation and proliferation of engineered T-cells and the extensive release of inflammatory cytokines. Symptoms can range from mild, flu-like symptoms to a life-threatening condition requiring intensive care. For allogeneic cell therapies, graft versus host disease, GVHD, is a significant risk where immune cells from the donor, the graft, attack the recipient's tissues, the host. Insertional mutagenesis is the most significant genotoxic risk associated with integrating vectors, such as lentiviruses and gamma-retroviruses. When the vector inserts its genetic payload into the host cell's genome, the integration site is semi-random. This creates a risk that the vector could insert into or near a critical gene, with potentially catastrophic consequences. Integration near a proto-oncogene can lead to its aberrant activation, driving uncontrolled cell growth and causing cancer. Conversely, integration within a tumor suppressor gene can disrupt its function, removing a critical brake on cell proliferation. This risk is not theoretical. It was observed in early gene therapy trials for immunodeficiency disorders, where several patients developed leukemia years after treatment. Modern vectors are designed with safety features to mitigate this risk, but it remains a long-term concern that necessitates extended patient monitoring. Integrating vectors, such as lentiviruses and gamma-retroviruses, pose a significant genotoxic risk due to insertional mutagenesis. This occurs because the vector semi-randomly inserts its genetic material into the host cell's genome. Such an insertion can have catastrophic consequences if it occurs in or near a critical gene. For instance, integration near a proto-oncogene can aberrantly activate it, leading to uncontrolled cell growth and cancer. Additionally, integration within a tumor suppressor gene can disrupt its function, removing a vital control against cell proliferation. This risk is not merely theoretical. It was observed in early gene therapy trials for immunodeficiency disorders, where several patients developed leukemia years after treatment. While modern vectors incorporate safety features to mitigate this risk, it remains a long-term concern requiring extended patient monitoring. Off-target effects is the primary safety concern for gene editing technologies like CRISPR/Cas9. The guide RNA is designed to direct the Cas9 nuclease to a specific 20 base pair sequence in the genome. However, the nuclease may inadvertently bind to and cut other genomic sites that have a similar, but not identical, sequence. These unintended cuts, or off-target effects, can lead to deletions, insertions, or other rearrangements at unintended locations in the genome, with the potential to disrupt important genes and cause adverse health outcomes. Extensive preclinical work is dedicated to designing highly specific guide RNAs and using high-fidelity Cas9 enzymes to minimize this risk. Given that gene therapies are intended to mediate permanent or long-acting biological changes, there is a recognized risk of delayed adverse events that may not become apparent for years or even decades after administration. To address this, the FDA and other global regulatory agencies have established requirements for long-term follow-up, LTFU, studies for patients who participate in gene therapy clinical trials. The primary purpose of LTFU is to monitor the long-term safety and assess the durability of the therapeutic effect. Key safety concerns being monitored include the potential for delayed oncogenesis, cancer development, due to insertional mutagenesis or off-target effects, as well as any other unforeseen long-term complications. The Food and Drug Administration's, FDA, approach to LTFU has evolved. Earlier guidance suggested a blanket 15-year follow-up for all gene therapies. However, the current guidance, finalized in 2020, advocates for a more nuanced, risk-based framework where the duration and intensity of follow-up are tailored to the specific technology and its known risk profile. A 15-year follow-up is recommended for products with a higher potential for genotoxicity. This category includes integrating vectors, such as lentivirus and gamma-retrovirus, due to the risk of insertional mutagenesis, as well as all gene editing products, such as CRISPR, zinc finger nucleases, ZFNs, and transcription activator-like effector nucleases, TALENs, due to the potential for delayed consequences of off-target effects. A shorter duration of up to 5 years is generally recommended for adeno-associated virus, AAV, vectors. This reflects the lower risk associated with AAV, as it primarily remains as a non-integrating apism. The requirement for up to 15 years of follow-up represents a paradigm shift in post-market pharmacovigilance. The safety assessment for these therapies does not conclude at the end of a pivotal clinical trial. This long shadow of risk creates unprecedented logistical challenges for trial sponsors, clinicians, and patients in maintaining engagement and collecting high-quality data over such an extended period. It also means that the complete safety profile of these transformative therapies will not be fully understood for many years to come. This evolving regulatory landscape, which has shifted from a one-size-fits-all rule to a more scientifically grounded risk-based approach, demonstrates that regulatory agencies are learning and adapting in real time alongside the science. Clinicians must remain aware that the standards for monitoring and best practices are dynamic and will continue to evolve as the field matures. The field of gene and cell therapy is advancing at an extraordinary pace, with ongoing research focused on overcoming current limitations and expanding the therapeutic reach of these platforms. Research efforts are primarily focused on improving the delivery vectors, particularly by designing novel adeno-associated virus, AAV, capsids. This involves using directed evolution or rational design to create vectors that can evade pre-existing antibodies, reduce immunogenicity, and specifically target tissues beyond the liver, such as the heart, lung, and brain. For lentiviral vectors, the goal is to develop non-integrating lentiviral vectors, NILVs, that deliver their payload as a stable apism, combining the large packaging capacity of lentiviral vectors, LVs, with the superior safety profile of AAVs. Regarding advanced gene editing technologies, the CRISPR/Cas9 system is considered the first generation of precise gene editing tools. Newer technologies are emerging that offer even greater precision and safety. Base editing uses a modified Cas9 enzyme, fused to another enzyme capable of directly converting one DNA base to another, e.g., C to T, without creating a double-strand break, DSB, in the DNA. Prime editing is a more versatile search and replace technology that can make a wider range of precise edits, also without inducing a DSB. By avoiding a DSB, these next-generation editors may significantly reduce the risk of off-target effects and other unwanted genomic rearrangements, making them potentially safer for therapeutic use. Addressing scalability and accessibility is crucial, as the high cost and logistical complexity of autologous cell therapies present significant barriers to broad patient access. A key objective for the field is the development of allogeneic, off-the-shelf cell therapies. This approach would utilize cells from healthy, pre-screened donors to create large, uniform batches of a therapeutic product that could be available on demand. This would transform the manufacturing paradigm from a personalized service to a more traditional product, potentially lowering costs and increasing accessibility. A primary challenge with this approach is overcoming the host immune system's rejection of the allogeneic cells. Finally, the ultimate goal is to expand therapeutic indications beyond current successes, which have been concentrated in rare monogenic diseases and hematologic cancers. Active research is underway to apply these powerful technologies to more common and complex diseases, including prevalent conditions such as cardiovascular diseases, e.g., heart failure, neurodegenerative disorders, e.g., Parkinson's and Alzheimer's disease, and challenging solid tumors. Gene and cell therapies have transitioned from theoretical concepts to clinical realities, offering transformative and, in some cases, curative potential for previously intractable diseases. For healthcare professionals, a nuanced understanding of this field is no longer optional but essential. This requires appreciating the fundamental distinctions between in vivo and ex vivo strategies, the specific attributes of different viral and non-viral vectors, and the precise mechanisms of genetic manipulation, from gene replacement to gene editing. The current landscape of approved therapies demonstrates a clear, biologically driven rationale. In vivo AAV-based approaches are used for gene replacement in stable tissues, while ex vivo lentiviral-based modification of hematopoietic cells is the cornerstone for treating blood disorders and creating cellular immunotherapies. The clinical application of these treatments is a complex, multidisciplinary endeavor, demanding specialized infrastructure and long-term patient commitment. Significant challenges remain: navigating the host immune response, ensuring long-term safety from risks like insertional mutagenesis and off-target effects, and overcoming the immense manufacturing and logistical hurdles are paramount. The regulatory framework, particularly the requirement for long-term follow-up, reflects the permanent nature of these interventions and the need for continued vigilance. Looking forward, the field is poised for continued rapid evolution. Next-generation vectors with improved targeting and safety profiles, more precise and safer gene editing tools like base and prime editing, and the development of off-the-shelf allogeneic therapies promise to overcome current limitations and expand the scope of treatable diseases. As these technologies mature and move from treating rare conditions to addressing more common ones, they will become an increasingly integral part of the modern medical lexicon, demanding that all healthcare professionals are equipped with the knowledge to guide their patients through this new era of genetic medicine. This was an episode of the Nexus Clinical Podcast. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.